climate science. I've known Maggie for quite some time. When I was a master's student, I saw her give a talk at UNC Charlotte, where I did my master's and PhD, and we started working together over the past few years on using spatial analysis to study mental health in North Carolina, and she'll provide some insights to that today. So I'll just give a brief bio for Dr. Sugg before we get into it. Dr. Maggie Sugg is an associate professor in the Department of Geography and Planning at Appalachian State University. Her research focuses on the space-time or spatial temporal patterns of health illnesses and how these patterns relate to the environmental, socioeconomic, and climatic determinants. Dr. Sugg has 70 publications on the intersection of geography and public health. And I'll say that's very impressive coming from a teaching university. She's very active in research despite the teaching load. She is a recipient of the National Science Foundation Career Award in the Environmental Protection Agency's Star Fellowship in Public Health and funding from the National Institute of Environmental Health Sciences, the National Science Foundation, and the National Institute of General Medical Sciences, and the American Foundation for Suicide Prevention. So very happy to have Maggie talk about some of her recent work, and take it away.
Yeah, thank you so much, Michael. Special thanks to Michael, who's been a great mentor and collaborator to us at Appalachian State. Hopefully you can see my slides okay. But today I'm just gonna kind of give you like a survey of some of the work we've been doing, just not go in a lot of detail methodologically, but kind of a sampling of what we're working on using geospatial data and how we're trying to address some of these complex, like wicked problems using this geospatial perspective. And most of my work that I'll talk about today, it's definitely a team. Michael's part of that team. Have a close collaborator also at NC State, Jen Runkle, and then lots of students who are funded at the master's level and undergraduate level under these grants from NIH and the NSF Career, as well as the AFSP. But yeah, thank you so much for having me. And I welcome any questions or feedback just at the end. But as you all, just kind of to provide some significance, mental health is a significant contributor to the global health burden. Nearly 1/4 of people worldwide will develop a mental health disorder in their lifetime. Most of these are occurring early in the life course, early, like by age 14 or by age 24. So if we can capture or identify these early in life or prevent them, that's a real opportunity for intervention. Suicide's also a leading cause of death, and just in 2020 alone, there was 1.20 million suicide attempts. So it's definitely a public health crisis. Because of this and the rise in mental health issues, particularly among adolescents, the U.S. Surgeon General in 2021 did the unprecedented task of issuing an advisory about protecting mental health, particularly among adolescents. And he really had a lot of recommendations throughout the advisory, but one of them really highlighted like the multi-scale approach of how, factors at the individual, the family, the community, the environment, how these are all very complex, and the complex interplay is affecting youth and mental health among youth. And so, mental health is a national crisis, and really he highlighted the need for multidisciplinary approaches to address this challenge. And I see geography and geospatial data as one of these areas that's needed to try to understand and mitigate this ongoing crisis. As you all know, at Johns Hopkins, I'm sure, health, but particularly mental health, can be really difficult to study. With health data, there's privacy concerns. A lot of mental health data is survey-based, which has its own inherent biases. There's a lot of it's limited to cross-sectional research design. It's not longitudinal. There can be stigma when, looking for mental health or trying to address it. And then from a research perspective, it's really hard to determine causal relationships and understand the causal mechanism. Big data, particularly geospatial data, provides an opportunity for researchers to kind of understand mental health at a community level and mitigate it as well. And so that'll be kind of one of my themes. So today I'm just going to give like a survey of some of the work we're working on, some of the challenges we're trying to address. I kind of break it up into two main areas of research under this mental health umbrella. One is looking at the geographic patterns, and this is my work with Michael, really trying to understand where are these mental health outcomes spatially concentrated, and this is funded through my career award. It funds the students who help us with this work. And then a second avenue, and my background's also really strong in climate health. That's what I was trained in with my PhD. And so we're trying to also understand what are the climate implications of mental health. So when a climate disaster occurs, what are the mental health outcomes? And that's a lot of my NIH funding. So I'm kind of going to give an overview of all of this. And I welcome any feedback along the way. So the first question, so broadly, we're interested in just the geographic patterns of mental health. So where are they spatially concentrated? And the methodology, the rough methodology we're using is just cluster analysis. So trying to take these mental health outcomes, mortality or morbidity data, and just map them and then use simple cluster analysis to identify where there are a much higher risk of these outcomes compared to other locations. And we're predominantly using Coldroff spatial scan statistics. So either looking at it spatially or space-time. And this is a moving window that takes into account the population at risk. And from these, we identify clusters where there's a much higher risk of those outcomes compared to areas outside the cluster. And we also adjust for age and race and insurance when possible too. Once we determine the cluster location, we try to tie it back to individual and community drivers or determinants. And so we link the cluster location to individuals to try to understand why we see clustering among these individuals, what are some of the commonality among them, what are some of the community drivers to try to understand like some hypothesis generating for why it's occurring where it is. And we're just using simple like generalized estimate equations when we have repeated measures or logistic regression when we have mortality data to answer this question. And the main data set that we're using for this is just for North Carolina. We're using we have near complete spatial temporal coverage for emergency department visits across the state, minus military bases. And so we have all emergency department visits from 2008 all the way up to 2022. And so this is where we're deriving a lot of our mental health outcomes. We code for it either ICD-9 or ICD-10. And we look at it either primary or secondary diagnostics. Within the data itself, we also have zip code residential location, as well as age, race, and insurance. And so that's one of our main sources of data. For the mortality data, we're using North Carolina Violent Death Reporting System, and this includes really detailed information about violent deaths, so suicide or homicide, and we are able to geocode that actually to the point of residence, so a point level data. And so now I'm just kind of going to give you a sampling of some of our work we've done answering this question. One of our first studies, and Dr. Desjardins also included in it, was looking at adolescent suicide and trying to understand where adolescent suicide was concentrated. Adolescents were defining as under age 24. And we just wanted to know where they're spatially clustered. And so we noted, we did the Coldroff spatial scan statistic, just spatial scan. And there's 4 main clusters. We see one in Western North Carolina, which is very much something we expected and hypothesized. This is a rural mountain community. This is generally where we see more suicides across demographics. But what was interesting is we also saw suicide clusters in the eastern part of the state, which was not something we hypothesized. Within these clusters, we're seeing much higher risk levels compared to outside the clusters. And the clusters themselves also have a lot of heterogeneity within them with different local relative risk. In addition to adolescent suicide, we were also interested in suicidal behaviors as measured through the emergency department visits. So these are like self-harm, And we were really surprised to see a different pattern. So with these types of emergency department visits, we actually see more in the eastern part of the state, the coastal plain. And this area is a little bit higher poverty, a lot more minority populations. And we saw less in the western part of the state, which was a surprising finding. And so once we've identified these clusters, one of our interests is what are the drivers of these geographic patterns? What are some of the individual drivers as well as the community drivers that cause, clusters to occur? What are an increased mental health outcomes? And so we had a couple variables that we looked at in detail. One of them was rurality or urban rural. Within the psychology literature and the mental health literature, I'm sure you're all aware of, but it's well established that rural locations have much higher rates of suicide than urban locations. However, from a geospatial perspective, a lot of times this rural urban is just like two categories, rural urban. But as you know, there's like a rural urban continuum. It's actually quite more complex than that. And a lot of the studies today also focus on county level, and county can be quite large. Within the county itself, there can be a lot of heterogeneity between rural and urban. So one of the areas we were trying to improve upon was looking at rurality, or look at the rural urban continuum across a couple of different categories. And so we used USDA RUCA codes and their predetermined categories to look at rurality and to look at it across a continuum. And these codes take into account not just if a location's rural or urban, but also commuting patterns, flow patterns, and it kind of gives us a different idea of rural and urban. And other variables that we included in our analysis include income segregation and structural racism. We are measuring this through the index concentration of extremes. This was a metric that was really popularized by Nancy Krieger, a spatial epidemiologist up at Harvard. And it gets at, it's been considered a measure for structural racism when you look at Black-white disparities, as well as poverty when you look at income disparities. And we're calculating all of this at the ZICTA level. And so with this information, again, we're taking our cluster locations, and some of these clusters you can see have really high relative risk, so much higher than the surrounding area. And just this in itself is a significant finding. We were able to use these maps to help fund a public health AmeriCorps program here in Western North Carolina that does psychological first aid. So like when we talk to our state partners, they just love these maps because that helps them target their interventions. So just a side note I forgot to mention. But from a scientific standpoint, some of the drivers we're seeing individually, again, we're looking at under 24, but even under 24, we're seeing a military signal. We're seeing much higher rates, a 1.86 ratio of military suicides, particularly in cluster locations compared to non-cluster. We're also seeing much higher rates of Indigenous Americans. So in the western part of the state, we have the Cherokee Indians. I don't know if you can see my pointer right here. And then we also have Lumbee, although it's not federally designated, down here in the eastern part of the state. So we see a higher rate for these populations. I do have to caveat that our sample size is pretty low when we look at suicides, but we're all seeing an increased incidence. A real significant finding compared to some of the previous literature is this micropolitan. So when we compare a reference variable of an urban location, we actually see higher rates of suicide, adolescent suicide in these micropolitan locations. So they're rural, but they're not the most rural. They're actually kind of like suburban right before metropolitan. And so that's a significant finding. So it's not the most rural, it's kind of these micropolitan communities within North Carolina that we're seeing elevated suicide risk. In addition, when we look at the ICE metric, we see a strong signal for low income, so high poverty locations, and we don't see much of a signal when we look at structural racism. We applied the same methodology to suicidal behaviors and noticed some interesting trends. This is measured through the emergency department visits. We see higher rates for Medicaid, it's kind of a proxy for poverty, lower for Blacks. And then that micropolitan, again, is a really interesting signal. And it's something that like a lot of our state partners are really surprised with and really appreciate seeing. And then again, a strong signal with low income communities as well. And so, you know, we have a lot of master's students, and so we're using the same methodology to apply these types of findings to other types of analysis. And so some of the other studies we've done looking at cluster statistics, but a different approach, include looking at multivariate cluster statistics. So this particular study led by Sophie Ryan, Dr. Desjardins was also instrumental for it. Looked at depression and suicidal behaviors during the early part of the pandemic. It compared it pre-pandemic to post-pandemic. And overall, so this multivariate statistic allows us to look at cluster co-occurrence for depression and suicidal behaviors. In the early part of the pandemic, we saw declines in mental health visits for emergency department visits. However, when we apply these clustering statistics, we are seeing locations that are having much higher elevated risks for depression and suicidal behaviors. So it's heterogeneous. Even though the whole state had declines, we are seeing locations with increases. And so these are locations where we both have depression and suicidal behavior, so really, really high mental health burden for these communities. And this is that same publication, when spatial and spatial temporal epidemiology, led by Sophie Ryan. And we can see locations where we see increases in depression, which are red, blue are where we see decreases, same with suicidal behaviors down below. Overall, we're seeing in the early part of the pandemic, so we're still trying to get those numbers for the later parts of the pandemic. We are seeing increases in these visits in rural locations. So rural locations are the locations that are predominantly seeing increases in suicide and depression co-occurrence. Some other outcomes we're looking at. So outside of adolescent mental health, one area that we've just started to become more interested in is maternal mental health. So maternal mental health is a condition that affects a lot of women, nearly 20% during their pregnancy. It can lead to very severe outcomes. So when a woman has a maternal mental health condition, it can increase the risk for hypertension disorders, HDP, severe maternal morbidity. So a lot of adverse outcomes. And so we were interested, we were the first to kind of think about, well, what populations are at risk and where are they located for these different conditions? And we've operationalized 3 different metrics for maternal mental health. The first is perinatal mood and anxiety disorders. These are the most common maternal mental health disorders. And they're often pre-existing, but also common during pregnancy. The second is one of the most least common, small sample size, but actually very severe mental health disorders, SMI. And this includes like psychotic disorders, bipolar disorders, so really, really severe conditions that occur during pregnancy. We have small sample sizes for this, but we see a much higher incidence for Black women for these particular condition. And then the third condition is newer conditions. So is conditions that are arise during pregnancy, and these are maternal mental disorders of pregnancy. And again, they're similar to PMAD in that they have a pretty high sample. And we've looked at their distribution across the state using the same Koldroff spatial scan statistic and noted different populations at risk. We're also taking the same approach and led by a different student, Sarah Ulrich. Dr. Desjardins also involved, looking at how these conditions, these maternal mental health disorders, changed during the pandemic, which was a very stressful time. And overall, already we see that when we look at all maternal mental health disorders, we actually see an increase statewide. So it's one of those unique populations that had an uptick for these conditions statewide. And we see differences when we look at pre-pandemic compared to post-pandemic. This top map is severe maternal illness. And so those are those really severe conditions, psychosis, bipolar, PMAD. These are these pre-existing mood and anxiety disorders, and then MDP. And in general, we see that it's not, there's a lot of heterogeneity, and we're still trying to understand what some of the drivers of these patterns are. But again, we're some of the first to look at the spatial patterning of these different maternal conditions. In addition to just doing clustering, we're also interested in like tying it, doing more ecological analysis, so spatial ecological analysis. A student one of my students, Sophie Ryan, also did her thesis on green space. Is trying to understand how green space may impact the mental health relationship. Again, we're limited because it's ecological, but in general, green space is considered a potential low-cost intervention. And we wanted to look at different types of green space. So we looked at just like tree cover, so being able to see green, which is the map B. And then map A, looking at green space accessibility. So this is like locations with parks or national forests. So these are areas like within the PADIS data set where people can go and like be in a park or a national forest. And that's A. And so we wanted to tie this to some of our mental health data to see if there was a relationship. Overall, we found that green space was a protective factor. However, it was strongest for this like private green space. So just having like tree cover seemed to have the strongest relationship. But public green space, so parks, etc., benefited mental health when we looked at it ecologically, but more so in urban areas rather than rural. Sophie's taken it a step further and looked at public green space across a couple different measures. Again, ecological analysis. She's looked at green space quantity. So, and this is using that accessible parks, that PADIS data set. Green space quality, which is really hard to measure, but we're trying to operationalize, is perimeter to area ratio of the green space, kind of like that's kind of considered a proxy for biodiversity to see if that exists. We've also experimented with like Google reviews for different parks to see if that could be a proxy for quality, but that's a little messy. And then accessibility. So how far are people from this publicly accessible green space? And overall, we've noticed some pretty interesting trends across the rural-urban continuum in North Carolina. Urban communities with the least green space had higher rates of suicide ideation, similar for suburban and small towns. When we look at what we operationalized as green space quality, we saw no significant results. And I've talked to some colleagues who specialize in green space, and this green space quality metrics just really hard to quantify, and this potentially the way we operationalize it perhaps is not ideal either. When we look at accessibility, we see some interesting trends. The more accessible green spaces in urban areas, we see a reduction in suicidal behaviors, as well as rural and isolated, which was surprising. And we hypothesized that, a lot of these parks, particularly in rural and isolated communities, they're also economic opportunities, particularly in North Carolina. So these forests, etc., allow more economic revenue, and perhaps that's why we're seeing a signal here. And that kind of summarizes like my results for this type of analysis. So trying to understand the drivers of mental health and some of the contextual and compositional factors that are influencing these patterns. Another big area of research for us is looking at the climate implications of mental health, and particularly from climate disasters. And this is an area that I haven't been collaborating with Dr. Desjardins, but I'd welcome it. And this has predominantly been funded through NIH. And so it's a separate line of research, but also has a lot of geospatial connections. And again, just giving a survey of kind of what everything we've been working on. And so switching gears, as you know, climate change and health is, a well-established field. And the impacts of climate change on health are well known. The latest national climate assessment was just released this week, and they've highlighted a lot of health impacts, particularly for marginalized communities. And so this is considered one of the defining issues and for the public health community. And for me, when I think about climate change, I think of it as a threat multiplier. So it's taking these mental health disparities we've seen in my prior work and amplifying them. It's amplifying these disparities. It's making them much worse. Just like our previous work, we're similarly focused on children and pediatric populations. So, children are impacted by disasters, particularly climate disasters, and they can have continued trauma-related symptoms on a much longer time period. Yet little is known about this population still, particularly against the backdrop of this mental health crisis. And so that's a research gap we're also trying to address. And for this type of work, we're using kind of an interesting digital data source, a geospatial data source called Crisis Text Line. And Crisis Text Line, I don't know if you're familiar with it, but it was a nonprofit. It was started in 2018. It has national coverage. It's also now available internationally in several different countries like the UK. And what it is it's a service predominantly used by adolescents. And what they do is they text in to Crisis Text Line, and they're paired with a crisis counselor. That crisis counselor is a volunteer who's gone through training. And so that's the general model. It's fairly widely used. Over 80,000 people have used it, mostly adolescents, so mostly under age 24. And to date, last time I checked, we had nearly 9 million conversations. And so this is a really interesting data source for us to leverage because it addresses some of those limitations of more traditional data. For one, we can get the data in real time. So as you know, with like hospital administrative data or mortality data, there's really long delays to get that data. With crisis text line data, we can get that data immediately. So it has a lot of potential when you think about like public health surveillance, particularly like in the context of a climate disaster or the pandemic. And we have a really strong partnership with Crisis Text Line. We've been working with them since 2016. And so with the crisis text line data, what we get is at the end of each conversation, the crisis counselor will tag that conversation with different type of crisis events. And there can be they can be co-occurrence of these different tags. But there's different types. They can relate from depression to isolation to different types of abuse. We have suicidal thoughts. And within the suicidal thoughts, there's like a ladder. And that ladder can signal the type of risk. And in some cases, crisis text line will initiate an active rescue in the most severe cases. But this is very rare. It only happens like less than 1% of crisis text line conversation. In addition, with crisis text line, about 25% of the texters also provide detailed demographic data. And so, again, 25% is not great, but when you think about like 9 million conversations, it's a ton of data, which is great when you think about like big data and geospatial research. And this data includes like information on age and includes gender identity, so male and female, as well as sexual gender minorities. And this is also an advancement because a lot of the hospital administrative data does not include sexual gender minority information. And I see people trying to use like clinician notes and other things to try to discern sexual gender minority status, but the crisis text line data, we actually have that information, which is exciting. And then we have racial and ethnic identity. And sometimes, like during the pandemic, we have other questions. And so we're able to also look at repeat texters, so people who've engaged with the service multiple times. And so we've been working a lot with Crisis Text Line, again, since 2016. This was one of our first publications looking at just the pattern of suicidal thoughts and how it compared to actual suicides. And we saw, lower help-seeking behaviors in rural locations where there's actually much higher suicide rates. And this was done at the county level. We've also done a lot of interrupted time series analysis, so quasi-experimental type design, looking at different events. So this was the release of 13 Reasons Why, which was a Netflix series that dramatized suicide. And we were curious to see if there was an uptick in crisis text line usage. And that's why we originally started the study, but actually, in actuality, there was also a couple celebrity suicides. And those were like some of the main drivers of upticks in suicidal crisis usage. And during the pandemic, it was interesting to use the data to look at some of the mental health patterns across the US. With the demographic data, we had actually really detailed information about essential workers. So we were able to see which crisis users were essential workers or who were also children of essential workers. So we had that information too. And so we were able to make comparisons with essential workers and then crisis users, as well as crisis users of the same age group, and then children of essential workers and crisis users of the same age group. And with that, we saw some notable trends too. With workers across the pandemic, we saw much higher rates of grief compared to non-workers of the same age, as well as suicide capability. For children of workers, we also saw high rates of grief, but as well as substance use, particularly in the later parts of the pandemic. But what I really wanted to talk about, and what our funding was about, was looking at the causal association with climate disasters. And so we've looked at a lot of climate disasters, trying to understand this association. I'll just highlight a few, again, trying to give you kind of a survey of what we're doing and how we're using geospatial data to answer some of these complex problems. And so I'll talk about Hurricane Florence. We have a paper on that. Hurricane Laura, which occurred in 2020. If we have time, wildfires in 2020. I won't talk about it, but we also have a paper looking at the Texas 2021 winter weather event that caused a huge power outage. We looked at that. And then high temperatures. I'll also discuss how high temperatures and what we see with the crisis text line data when we look at those. And in general, we're using quasi-experimental analysis for this, so interrupted time series, or a difference in difference, but like a spatial difference in difference. And so with the spatial difference in difference, we're taking into account locations that were impacted by the storm and comparing them to locations that were not, ideally within the same state, to meet the assumption of parallel trends. And then a lot of times we're also doing interrupted time series analysis, which is another quasi-experimental approach, and we're using ARIMA modeling to get at that. And again, crisis text line data. And one of our first studies we looked at was Hurricane Florence, which impacted North Carolina in 2018. It was a major event. It was a 1 in 1,000 year flood event. It caused significant damage to the eastern part of the state. People were out of school for many months, power outages, everything. And it occurred right before or right after Hurricane Matthew, which hit in 2016 at the same location, more or less. So kind of almost like a compounding event. And we measured impacted areas based off FEMA disaster declarations at the county level. And I won't, this is usually try to show maps, but this is some of our ARIMA models that we used to look at it. Overall, we saw no trend in Florence when we looked at all crisis outcomes. However, when we look at specific ones like suicidal thoughts, which are some of the more severe crisis outcomes, we did see an increase, so 23%. As well as anxiety and stress, we saw 17%. But a cool thing that we did, and why I highlight this study, is we had that emergency department data, my SHEPS data. And so we did the exact same methodology with our ED data. And we noted a parallel increase with the same demographic as the crisis text line data. So this was really exciting to us because it kind of validated crisis text line is a proxy for the mental health of the community. But again, it has that real-time capability, no delays, we get it de-identified. So it was an exciting new novel data stream that could potentially be used for this like public health surveillance. Also looked at several events within the pandemic itself. One was wildfires. We had a study published in Stoughton with it. Used that spatial difference in difference. One interesting finding is that we noted a decrease in after the wildfires, but remember these wildfires occurred during the pandemic. And so depending on what we use, difference in difference, we noted a significant decrease for several outcomes and no significance when we used interrupted time series analysis. And our results were surprising, but we hypothesized and what we could see from our analysis that the COVID pandemic was the social stressor was the main driver of mental health outcomes with crisis text line data rather than the wildfires. And an interesting area we're also taking it is looking at sexual gender minorities. So we have Hurricane Ian, and we looked at Hurricane Ian, which hit last year across Florida. And we were comparing it using this quasi-experimental design. We're comparing it to sexual gender minorities. And we're trying to see if there's different trends after disasters for this group, which is already more vulnerable than your typical adolescents. And we do note, and this paper is under review right now, that we see higher rates of suicide ideation and intent, depression and self-harm compared for this sexual gender minority group compared to our referent group after Hurricane Ian. And we're looking over a shorter time period for this, so approximately 6 weeks. Other studies we've looked at include Hurricane Laura, and we were interested in this particular hurricane because it co-occurred with a lot of different ongoing stressors. So we had the pandemic, we had the George Floyd protests, we had the 2020 presidential election. And we were trying to see which one of these, when we look over like short acute timescales, do we see the most spikes in mental health. We saw notable spikes across most of these events. However, we saw the most significant increases, particularly for the pandemic, and one of the largest was for the 2020 election. And this is for the state of Louisiana. Those were the main, those increased the magnitude of the service the most, although we did see increases for Laura and the oh my gosh, I can't speak, George Floyd murder protests. And lastly, again, giving you a survey, another area, but it's kind of interesting to look at is high temperatures. And we're using the crisis text line data. When you look at mental health and suicide, there's across worldwide, there's a link with higher temperatures. Generally, we're seeing increases in mental health or suicidal behaviors. And we were interested if we saw this also in the crisis text line behavior. We used a different methodology, a distributed lag nonlinear model, which is common in environmental epi. And we did note in certain locations, particularly high latitude locations, we see a strong signal. So with higher temperatures, we see more crisis text line use. And so this is for New York, and you can see the models right here. At these higher temperatures, we see a much elevated risk for crisis text line use. But an interesting finding is when we look at some of the southern latitude locations like Atlanta, we don't see quite the same dose response. And then when I look at my ED data, emergency department data for the state of North Carolina, we also don't see that same dose response. And I don't know, we hypothesize perhaps, this population's acclimated to the heat, they're used to the heat, and so we don't see that strong signal, but we're still investigating it. And so some next steps when we think about, geospatial and public health surveillance, crisis text line is exciting to us because it's a scalable crisis intervention and has the potential to provide like real-time situational geospatial surveillance when these types of disasters occur or a pandemic occurs. You can see it pretty quickly, and that's exciting from a public health perspective. And I kind of was thinking about how to wrap up my talk, and I thought one area was to kind of think about the future of geospatial analytics and GIS. I think climate and health is a really interesting, area where a lot of research is still needed. I think precision public health surveillance is another one. We can provide situational awareness. I know Johns Hopkins did that with the COVID pandemic in their dashboard, but there's other potential out there. There's lots of other mental health conditions that also we could do some sort of surveillance for. I also think, geography and GIS allow for us to embrace complex problems, wicked problems, and convergent science, and integrate, environmental, climate data sets, census data. Allows us to embrace all this data and integrate it and address some of these complex problems that, we really benefit from it. We break down those silos across disciplines. And some of my final remarks, risk factors for youth and mental health. I think we see a lot of variation across the rural-urban continuum. Across disasters, we're seeing, and we're still looking at it, social stressors seem to be the largest driver of these crisis events. And we're working right now trying to understand compounding disasters, like when a disaster occurs during the pandemic, how does that affect mental health? But overall, I think there's an important place for geospatial data and for geographers to address youth mental health. And there's still a lot of work to be done. So collaboration is encouraged, and there's a lot out there. And I wanted to give a special thanks. Obviously, this is a team, so I have a lot of colleagues. Jen Runkle is my dual PI in a lot of my grants. Michael Desjardins has been integral for mentoring us through these different processes. And then my two psychologists, Kurt Michael and Marty Thompson, they provide us the expertise in that area. And then I have a lot of masters and undergraduate students who help facilitate that process. Also, just a plug, we're always trying to recruit students. So if you have any wonderful undergrads, I'm happy to train them at the master's level, then send them back to you guys for the PhD. So please keep that in mind. But thank you for your time.
Thank you, Maggie. That was one of the best talks I've seen in a while, especially just making everything graphically, no bullet points, and just the pictures to the science was great. Of course, maps for GIS Day.
Yeah.
There's questions in chat, but I wanted to start off with, you said our work, I didn't even know this actually, our work on the mental health stuff and the clustering was used to inform the public health folks in North Carolina.
Yeah.
Speak to that, how GIS was used to actually inform policy, which doesn't often happen. You need some connections and need to kind of, lack of a better down so they understand, since cluster detection and modeling could get quite fancy, right? So how did that work out?
Oh, you mean can you repeat your question? Sorry.
It should be used for making policy decisions. You said it was being used for them to improve interventions.
Yeah, unfortunately, public health is largely underfunded. So at the state, they only have so many resources. And so they love these maps because it helps them target where things are needed the most. And a lot of times they're just using, for the environmental type work, they use EG Screen or CDC SOVI. That's what they're using to drive their decisions. But when we have actual mental health data, I think it helps them, it gives them even more information for that decision. And so they love it. And, they don't have the resources to do it, but it takes what little money they do have and allows them to allocate it where it's needed.
Yeah, that's wonderful. I mean, StatScan could get fancy, as you know, and just explaining that it's excess incidents compared to what we would expect should be convincing enough. I think Marnoush had her hand up, and then I'll get into the chat.
Oh, well, thank you, Michael. Thank you very much. That was a great talk. So I basically wanted to ask about the connection between implementation science and the geospatial stuff that you talked about. But Michael briefly touched on that. You basically pretty much answered that, except for implementation scientists in academia, if that interaction is developing or has developed, or where is that happen? Where is that at?
Well, unfortunately, it's not, so I'm I'm at App State, so I definitely would need an implementation scientist, but that's an area we're missing from our team, and that's an area I'm trying to improve upon. Is so we've identified this population, now what? And some of the ways we've done that, I was able to fund an intern through my NSF grant to work at the state. So she works with me, but she's funded to go work at the state public health office. That's not quite implementation science, but it's, us trying to move our research out into the world. But that's an area I'd really like to grow. And
yeah, so it's a growing area and you're going that direction. Okay, that's great. Thank you.
Thank you.
I see another hand up. Maya, if you want to ask a question.
Sure, thank you. Thank you so much for this lovely presentation. I had two brief questions. One was postpartum depression disorder categorized as an SMI, PMAD, or the third category you listed, if it was looked at all? I was curious about that.
Yeah, so I'll have to look at where it was, because I have the codes, they're in our pub.
Okay, yeah.
I think it was in PMAD, and we used another paper that highlighted pre-existing conditions, PMAD, MDP, or PMAD, SMI, and then new conditions, MDP. So we're using a foundational literature to make those definitions.
That makes sense. Okay, and
the paper. Yeah.
Sounds good. Yeah, I'd love to know which paper it was. Curious about PDD specifically. And then I think the second question was, I really appreciated the work that you've done with green spaces and adolescent health. And I was curious about if you've looked at impacts of maternal exposure to green spaces on child mental health. I read this paper that was in China, like a study conducted longitudinally focusing on children up to the age of 2, but haven't seen too much in the States. And I was curious if that's something you've explored.
Yeah, it's definitely an area of interest. We have a study that's published looking at maternal outcomes, not quite child, but maternal outcomes in green space for South Carolina. And we noted some, green space access reduced those outcomes, particularly in minority neighborhoods. Sure. And that's looking at accessible green space, not just greenery, but actually being able to access it. But yeah, not child, but we do look at adolescent mental health under 24 and see a relationship ecologically.
Great. Thank you so much for answering these. Yeah.
I think since it's fresh, relating to the access to green space, my question was, are you using the fancy access models, gravity models that could account for the amenities and kind of demand of the parks and green space versus simple network distance measures, which I assume that's what you were talking about, right?
Yeah, no, we're not using, this is just a real simple ecological analysis. We haven't, it's hard because a lot of the mental health data is at the ZICTA level. The only point data we have is the mortality data. So that's kind of a limiting factor where you could do that more advanced analysis, but you have the smaller sample size, unfortunately.
Excellent.
Yeah, maybe we can collaborate on it, Michael.
A distance can be powerful. Just is there an increase as distance increases? Especially network distance, you don't want to assume people travel like birds, right? So we always talk about that, obviously, in geography.
Yeah, Manhattan distance.
I think I'll leave the general question last. My last question was for the spatial difference and difference, which I commend you on. That's a very new area, spatial causal. And implementing that method, did you account for kind of the spatial autocorrelation between units, kind of to get at quantifying the spillover and protective?
Yeah, okay. Man, so I just submitted an NIH grant to do that.
Okay.
I should have talked to you before. Yeah, we have not done that. And I don't think a lot of spatial difference and difference, at least in my field, has not been doing that. But yeah, we wanted to look at the spillover effect because we haven't been. And I think there is something there because we are getting a lot of, we looked at Hurricane Harvey. We have a pub under review for that, and it's a null association. I think some of it's being washed because we're looking at the whole state. Harvey was so big, there's a spillover effect, even if it wasn't impacted. And so we're trying to tease that out methodologically. would love your input if you have time.
Yeah, I asked because I'm working on that for violence interventions in DC. So like, if you're near a neighborhood that has these gun violence interventions, is that a protective factor or is it spillover because the neighborhood's more dangerous? I assume you also looked at like reverse causality, making sure that's not taking place.
Yeah. And so, yeah, we have a model that we're going to use to look at that if we have time and if we get funding.
Yeah, wonderful. So out of my mouth, I think there is one more in chat. Student asked, do you have any related data towards waterborne disease? And I'm interested in looking at the effect of climate change on waterborne disease for my thesis.
Yeah, so I helped a student a while ago look at gastrointestinal ED visits and linking them to water. So you can definitely do that with emergency department data. But again, that's within the States. It's not available outside the US. And she didn't publish her work, but she did, this was at UNC, she did note a trend there, a delayed effect. And I think there's been some newer work actually that's been published since then, noting this type of like high precipitation event, uptick in gastrointestinal disorders in North Carolina. A lot of times it can occur after a drought too, the buildup of and then the heavy rain events filling it over. So I kind of answers your question. I think if you can get access to ED data, you can code for it and look at that signal.
Yeah, that's great. Back when I was in Charlotte, it's still going on, but the Healthy Wells Project, looking at arsenic, E. coli concentrations in wells across Gaston County, and I think they're expanding it across the state. So I'd be curious to see if climate change is also impacting well health. We're seeing a lot of wells are not getting tested regularly, and there's a lot of E. coli and arsenic, which is obviously not great for various outcomes, cognitive and other physical things, gastrointestinal. So yeah, that's a great question. I think it's a lot of opportunities to work on that. So
yeah, much needed too. There's not much work out there right now.
is there any other questions coming to mind? Type it in. Teresa?
Hi, thank you for your presentation. I was wondering if you could speak a little bit about using emergency department visit data for measuring like mental health outcomes, and kind of the limitations of that, especially with suicidal ideation too. I believe they track it in primary care. I don't know if they like necessarily give them a code. And same with like your PHQ-2 or PHQ-9, given in primary care settings. So I was wondering if you could speak a little bit about that and how you think that might affect your work.
Yes, definitely limitation, but well established, lots of people use emergency department visits. To me, I think it's just kind of getting at the most vulnerable people. So the people who, this is kind of like the tip of the iceberg that we're looking at. So I still think it's meaningful because we're capturing this population there's been a lot of news articles here in North Carolina, just how these people don't have access. And so they're forced to go to the emergency department. So when we write it up, we always try to frame it. I don't know if we succeed, but we try to frame it within that context. This is a very vulnerable group. We obviously aren't capturing everyone with a mental health disorder. But this is a group that is much needed and they have no other resources. Just like around the US, North Carolina, it's facing closing hospitals and all this stuff. So the access is really hard. And so that's why a lot, particularly youth, are forced into these emergency departments. Yeah, I would love to get more data. And that's why we try to fuse these different data streams, mortality, morbidity, crisis data. 988 is cool. So 988 is that federally number. We have a group in Louisiana that's giving us access to their data. So trying to put these all together to kind of get situational awareness is kind of the goal, but there's definitely limitations for each data set that we have to be conscious of. Thanks.
That makes sense. Thank you.
Within that emergency department data, have you seen any records on the social determinants of health? Because it seems like just through a lot of work recently, me and other colleagues, that we assume social determinants of health based on linking the patient data to the environment, right? The neighborhood census level. You know, is that being captured at all in these ED visits? I think clinicians should do a better job of asking those questions, because if you could intervene the social determinants of health, you might not need clinical intervention, right? So I don't know if you've seen any of that.
Yeah, I've looked at it because I was like real excited about those Z codes. I was like, yay! But when I actually looked at them, they're not being used very frequently as of my last round of data. There's a few of them there, but they're not being coded across the state, and not in a meaningful way to do analysis. But it'd be great if they, those could be included as a way to intervene too. It's great that they're available now, but from what I can see, I don't see them in the data set being regularly used.
We have time for maybe one more. All right, well, this presentation will be uploaded on our website shortly. We have a YouTube channel and on our center's website. And, just contact Maggie and myself if you're interested in this type of work, and happy to send over papers and resources and potential collaborations. And the nice, refreshing talk. And yeah, we wish we had you in person, but yeah, maybe next time.
Yeah, thank you so much for your time, everyone. And I welcome any suggestions or feedback. So thank you.
Yeah, thank you all for joining. Maggie.
For everyone.